So welcome to the next topic. It's on evidence-based practice. And essentially we're going to spend a few hours on this topic. And I think in British Columbia people came in thinking we're going to start talking about disease right away and different drugs. And so they were quite surprised that we actually spent the first morning really just talking about, you know, an orientation to the course and this evidence-based practice bit. So there's quite a few things that we'll go over here. And I think this is the part that we were I was at least very much impressed with how well this material resonated with your colleagues in British Columbia. So I'm curious to see how well you guys take this kind of information in.
And the reason that we do that is because, as we started off with, by saying, is we believe that the foundations of what we do should be based in evidence, regardless of what that evidence is. And so we'll work you through that process and put it into a context. And so we're going to go over a number of things. We're going to go over how we define evidence-based practice. We'll talk about how we formulate clinical questions, which is an interesting way about thinking, maybe a way that you hadn't thought about in the past, and how you search for information about this. And then we'll spend a whole bunch of time going, how do you look at a study? We're not trying to make you guys critical appraisal experts, but we think every healthcare professional needs to be able to understand the basic ways to look at clinical trial research. Because if you don't, you're missing a whole bunch of really useful information of showing whether things work or don't work.
And some of you may already know this material really well or not, so please interact with us if some of this stuff is coming easy to you or you're finding it difficult, and that tells us how much depth we should put in some of these topics.
And this is not a stats course. Oh, that sounds good. And
I think he's disappointed.
I know he's disappointed that we're not going to do talk about the Bonferroni procedure and ANOVA and all that. That's not what we're going to do, because that really doesn't serve your purpose very well. But there's a couple of little things that you need to know about that I think you'll be interested in to see. And we'll go from there.
So before kind of getting into it, I was reading something actually about a week ago as I was preparing this, and what I was reading referred to kind of the approach naturopathic doctors take with respect to being evidence-based. So we saw this kind of statement: naturopathic doctors aren't very evidence-based. And I'm wondering, and this is a bit of a hint, I'm wondering if you were going to be evidence-based or evidence-based minded about reading statements or doing things, how would you react to something like this, kind of a statement? So it's a bit of a trick question.
Is your first reaction like the picture?
Yeah, I mean, those are fighting words, I would think, if I was in your, you know.
Who's the author?
Yeah, who's the author? That's a very good question. What else? What do you mean by evidence-based? What's behind that? Excellent.
Yeah. What other things would you be thinking about?
Whose evidence, I guess that's
Okay, yeah, whose evidence are we talking about? Yeah.
Where they got their information.
Yeah, what's the source of that data?
Source, yeah.
And we're not just evidence-based, we have an art.
Okay.
And there's an art to it, yeah, absolutely. And medicine is as much art as evidence. There's no doubt about that.
I would ask, and compared to what?
Yeah. I love that question, and compared to whom? And those of you doing this at home, you should be asking questions in your mind too. Make this as active as possible.
Yeah. So compared to whom is a very important question, because that doesn't say anything, right? Is there anything else? So we've got compared to whom, but there's many other things. What other things would you think about? You talked about the types of, you said who said it, but what sort of other information would you want? How would you test this? How would you make it, let's say this is true. I'm not saying it is.
Well, I'd like to see the study, the statistics.
Mm-hmm.
Yeah. So you'd like to see, you know, what sort of data supports that statement.
Mm-hmm.
Well, who paid for that?
So
Sure.
now we're being cynical. No, I'm not just kidding. And so, when I say cynical, I don't mean there is a good reason to be cynical on occasion. I think it's too easy sometimes to be cynical, that, you know, whoever paid for it, it's their agenda. I think that does happen, but I think we will focus a little bit on that, but you're absolutely right. You want to know where it came from.
Yeah, well, the other piece to that is what's the motivation for coming up with something like this? Where did that come from? And that could be from who funded it. And in addition to what was stated around, you know, where did the data come from, is that data valid? And is it reliable? And when we use terms about valid, we essentially mean, is that data reproducible? And is that data, that's the reliable part. And is that data actually testing what it's supposed to test? So essentially, you wouldn't use a blood pressure cuff to test someone's cholesterol. That would not be a valid test for cholesterol. Maybe potentially a valid test for blood pressure, but not necessarily a valid test for blood pressure. So is the actual test that was suggested or things that they've done, is that data valid and reliable? Or is it very unique and not really a good test for this particular statement?
So what do you guys think about the words that are in that sentence? What words would you want?
Well, it has a negative connotation.
So it certainly has a negative connotation, but what about the actual descriptive words? What?
Very is kind of, doesn't mean.
Yeah, so the word very, what does that mean? What does the word very mean? It means what it means to you, and it may not have anything to do with what I meant when I said this, which I didn't say it. But if I did say it, you'd have to know what the word sort of very refers to. And when it says, even the word aren't, what does that really mean when we're talking about what's the magnitude of the difference, if there is a difference in evidence-based? And so you need to know what the words mean. And one of the things we'll probably have some fun with later on is some of the words that we use in medicine on a regular basis. Like, how many with a show of hands have never used the term high risk? You've all used it? I can tell you right now your patients haven't got a clue what you're talking about.
They're interpreting it differently than perhaps what you meant.
And I'm going to suggest you don't, most of the time, know what you mean when you say the term high risk, because the connotation could be, when you say high risk, people will think anywhere from 1% to 100 when you say the term high risk. They need a framework, and we're going to talk a lot about numbers, because it is all about the numbers when we're talking about some of this information. So we'll talk about that. And then, what is the gold standard of evidence-based? And we put that up just to be provocative, as you could probably tell, just for fun, to see, because we figured that you guys would defend this in a way that would be appropriate, and we think because we know I'm not aware of any evidence of.
No, we really didn't read this.
Than another.
James did state it on the plane on the way over here, but we didn't really read it.
No. But we want to realize that because you see a statement doesn't make it true, and if it is true, now if it was true, you'd like to know that. I think it might be an interesting thing. Maybe it would be good or bad. We don't know. And we wanted to put that up there to get you thinking about what are the things you need to think about when you see statements that say, I don't know, and I'm making this up, statins are terrible, or statins are good. Those are terms that phraseology is not useful to anybody. You really need to know what we know about them. And we'll talk about that as we go along.
And if you don't have a critical mindset...
Oh, sorry. Word is that is phraseology a word?
Yeah, I don't think so.
Is it not phraseology?
No. Mister, I was born in Britain.
I'm pretty sure...
Oh, I should just shut up then in case it is. Someone's going to Google something.
Can someone Google that word? Because I've been offended by this.
Really?
That my English ain't too good.
Offend number one. That's good. One of many coming your
So you
way.
can look up phraseology?
How about phraseology?
Yeah, maybe. Is it phraseology? Oh, I'm sorry. I put the emphasis on the wrong syllable.
No,
What?
It is phraseology.
Phraseology? So we'll edit that out. It's the phraseology, not phraseology.
Thank you. See?
Now, did you know it was phraseology? You just thought that was just completely a ridiculous comment. Yes. But you weren't being very evidence-based. Google is your friend, by the way. Before you make a comment about us, Google it.
Yeah, that's right.
Okay.
And did you know irregardless is not a word? A lot of people
No,
think
it is a word.
irregardless is
It is a
not
word.
a word.
Yes,
It's
it
not
is.
a valid word.
Yeah, it is.
Irregardless?
Yeah.
No, I think it's just regardless.
No, there is. It's a ridiculous word, but it's so often used. It's now being put in the dictionary.
No, stop. I don't believe it.
Yeah.
Anyway, okay. Okay, we'll start again.
Yeah,
I mean,
we'll
not
edit that
start
part out if we don't. But it's
We'll,
kind of an.
we'll start from the beginning.
See, now
again.
you've learned something. That there is a word irregardless, which is.
There isn't. That was my whole point.
Yeah, it was. See?
In the 20th century.
Really? In the that sounds like a long time
Yeah.
ago, the 20th century.
Yeah, back
Okay.
when there were no cars and there was no food or water. Yeah.
Wow.
It was
Okay.
added by a dinosaur. Okay, so what is evidence-based practice? Well, when we're talking about evidence-based practice...
Back up.
What?
I want to make these guys work. Okay.
I thought we already did all that.
No, well, no, now they're going to work more, but I want you to take a minute and write down or contemplate. If you had to define this to a 10-year-old or to someone who is not knowing or aware of what evidence-based practice is, how would you define it? So, and do this at home if you're watching this at home.
Just write it out.
Okay, that's about 15 seconds. Any volunteers wanting to read what they've written who haven't read what's on the website,
Yeah.
if you've got that open?
And if not, we will pick people.
Yes.
Okay, go ahead.
Eric.
Practice which utilizes currently available research data to inform clinical decisions and patient information.
That's not bad.
Yeah.
So practice that uses available research data to inform a decision and patient education. Okay. Does anyone want to build on that or had something different? Yeah, coach.
Well, I just said added also your clinical knowledge to it.
Okay.
Yeah. So there's the evidence, there's clinical experience or expertise. There's one thing missing. No, that research
How's the
is
evidence?
is that
Yeah. Eric did allude.
close, but
Yeah.
I'm not going to give it to him.
Okay. He's making you work for it.
And we actually mentioned it at the beginning of the sessions, and it's to do with why you have a practice. Patients.
Yeah. And their values and preferences.
Yeah. So when you look at the definition of evidence-based practice, it is not you need a randomized controlled trial. It's really important for you guys to appreciate that when we're talking about evidence-based practice, we are not solely talking about evidence from randomized controlled trials, cohort trials, or anything like that. We're talking about the best available evidence put in with clinical experience or clinical expertise, and this is often left out, interestingly enough, as given that we're health professionals, patient preferences. And we're going to talk about why patient preferences are really important, because the decision-making process for all of us is different. Sorry, go ahead.
This is a bit of a side note, but just in your experience, why is that the general thought process out there? RCT.
So the question is what-
Seems to be, they use the term evidence-based, they say RCT, and then they sit back and go like this.
Yeah. So the question is why do some people, not us, I hope, say that RCTs are, that's it, there's no RCTs, it
The
just
gold
doesn't work.
standard.
That's not how the world works. And in fact, you can't answer all the questions that we have with randomized controlled trials. Adil and I think would agree on this. You can answer a heck of a lot with a randomized controlled trial, and there's a heck of a lot that you can never know if it works without a randomized controlled trial. But randomized controlled trial is I would say, at least at present, the best way we have of identifying, does a therapy work? Not in an individual patient, but does it generally work? And so that's why people who sort of stick their noses up at evidence-based practices is because they believe that the concept of evidence means if there's no randomized controlled trial, there's no evidence. And evidence runs the spectrum from randomized controlled trials down to an N of 1 experience. So it's every cohort trials. When we talk about evidence, we mean everything. We don't just mean randomized controlled trial. Does that answer your question? Yeah. So it's really important, and that's an important point.
Maybe I'll add to it. There's certain features, and we'll go through that, of a trial process or doing research that helps eliminate bias, and the randomized controlled trial design typically incorporates some of those important features. So we'll talk about the values of and what that brings to the design of doing research for a therapy kind of question, and we're doing therapeutics, so those are the main questions. And I think then you'll get a sense. But you're right, some people are and we're like that with the work I do at Cadith. If it's not a minimum of that design, we sometimes won't look at that data for making recommendations on whether it gets in. So we do recognize that happens, and there's some rationale to it. I'll make one more feature. This quote that you see here comes from David Sackett, and you may or may not know David Sackett. He's actually from Ontario, and he's one of the 4 founders of this whole of what's evidence-based medicine. And this kind of came out in the late 80s, kind of 90s. It really changed the way people used to practice, really just more on anecdotal and clinical experience, and really brought to the forefront the importance of incorporating not only the best available research to what clinicians were doing, but also what the patient's values were.
And clinical experience is really important, but there's also a great line that clinical experience is often just blind prejudice. And we really want you to realize that it is very, very difficult for anybody, any clinician, to really be able to tell whether something is working in a patient. It really is difficult. You may think you know, but it is very difficult. And we'll talk about that as we go along.
So this really says the same thing. It kind of brings those 3 features together. just individual clinical experience that we're considering now to be kind of just outdated. If you did that in absentia of best available research in patients' values, if you just looked at the best available research and didn't really put into the context of what the clinician knows or is comfortable with, or what the patient wanted, well, that's a bit too cookbooky, and you can't. One size doesn't fit all. And just because the best evidence might support using this herb or this drug in a particular patient doesn't mean that that's what that patient wants or is willing to do, or doesn't mean that the clinician's comfortable using that in this situation. So even though the research trials support that, doesn't mean that's the right decision at that time. So when you incorporate all those three pieces together, you get what we're referring to as evidence-based practice. And just out of curiosity and kind of be honest, how many of you had a definition for evidence-based practice that didn't include these three components or had something different?
So
It's okay. Mark?
I was just thinking that the way evidence-based medicine is put to us, it doesn't
that way.
that way.
Yeah, and then that's why we felt it's really important to have a definition, because remember we talked about terms and phraseology? Is that if we were to just say evidence-based practice, you now have what you thought evidence-based practice was, whereas I've got a different definition of it, and so then we're not really communicating. So that's why we do a lot of the explanations up front. What we also want to let you know is what we think evidence-based practice is not. And we alluded to it on that previous slide, which is it's not cookbook medicine. A lot of people say, well, it's just you got to go within a randomized controlled trial, and that defines exactly how it works. But there's a whole bunch of translation, and we talked about the patient's features and values that need to be incorporated in it. So it is not cookbook, but boy, is it ever nice to know what we do know and what we don't know.
Mm-hmm. And in addition to that, there's guidelines that are out there, and guidelines say use this drug in this situation. It doesn't mean, again, that that's the right thing to do. You shouldn't necessarily just follow and look at just what the evidence is. It does help support and inform decisions, and so we'll talk about when we go through the different diseases, like when we talk about diabetes, and we'll say there's a particular drug that if you have type 2 diabetes and you're in this situation, the evidence really supports using this drug first. What drug am I talking about? Metformin, exactly. So, and then we'll mention that, but that doesn't mean every single patient you ever know should get metformin. There are probably some that may not be the ones to take metformin.
And some people suggest that evidence-based practice is a way to cut costs. It is sometimes used to cut costs, and I would suggest, actually, if you use the best available evidence, you actually will do less evaluations, less testing of people. You'll probably use less medications. You'll probably use less expensive medications because the best evidence usually is around the medications that have been out there longer. So, but it's not necessarily, it is taken over by some people to say, oh, you're just using evidence so you can cut costs, but that's not the concept.
It's more of a side effect of what happens than the actual intent.
It's not a bad side effect.
No,
in essence,
not necessarily.
from that. And so, it's really important to realize that there's many different ways of looking about what evidence-based practice is. So we're going to talk about why do you need to be able to sharpen your critical appraisal skills, and there's a variety of reasons, and we're going to give you the very basic stuff that you should be able to look at any clinical trial. You don't need to look at it in depth. You should be able to do it very, very quickly from that concept, and because just because something comes in the New England Journal of Medicine doesn't make it good. It doesn't make it bad, but it doesn't make it good. There's really good stuff in the New England Journal of Medicine, and there's crappy stuff. There's in much of the lower echelon of journals that aren't read by as many people, there's some really good stuff, and there's some really crappy stuff. So the only thing that you might need to know, if it's in the New England Journal of Medicine, people hear about it. That's the one thing that it's known for. Is why you like to get stuff in there, because then...
Yeah, it's a high-impact journal. People go to it. But the point is that sometimes you can be misled by the material that's in there, so you have to be kind of critically minded. Ask the questions, compared to who, based on what, in what particular patient population, what test are we talking about, what's the magnitude of the effect. These are kind of the questions that come into your mind, if they do, when you're critically minded. And so if you have sharp critical appraisal skills, you kind of know to look for those things. It becomes more of your paradigm rather than just accepting the statement for what it is.
And we think it's going to help make improved decision-making with your patients. And we can't guarantee anything, but we pretty much guarantee that. This will definitely change the way that you will think and how you will be making recommendations to do that. And it's really a tool to really stay current with advancing healthcare knowledge. Now, what's really useful to know is you don't have to stay that current. both Adil and I sit on the Patented Medicine Prices Review Board, and on average, 2 new drugs every year come out that are considered a substantial improvement. One of them is likely for conditions you've probably never even heard of. So every year, on average, 1 new medication that's a substantial improvement comes out. How many of you thought there would be more than that? Yeah, so most of you. But it's about 1. In the last year or so, it's been close to 0, depending on what group you look at. And it's actually a big problem. We are not having a huge number of breakthrough blockbuster drugs coming out, primarily because we've treated many of the conditions that we have with the medications that we have, and it's actually hard to do much better. We've got a long way to improve it, but it may be impossible to change some of the things because there's only so many things we can do with medications and so on. So it's really important that you need to be able to look at information, and there's a lot of crap out there, and you need to be able to filter that, and we'll show you how to do that as well.
Yeah, I was going to say, and when we say blockbuster or breakthrough, it means there's really no other drug to treat that kind of condition. So it's really added a lot of value. Most of the drugs there are a lot of drugs that do make it to market and are out there, but the limited value or the limited incremental benefit they have, especially for their cost, is really quite astonishingly surprising that it's not that much better than what we have. There's a few things that are moderate improvements and some that go a little further than that, but unfortunately we don't have.
Even that's not a lot of those.
There's not a lot of those. Maybe you can count them on one hand probably when you talk about moderate, substantial, and breakthrough kind of drugs. So it's if you are thinking critically, and you will get what we're going to talk about is these kind of PICO questions. Have you heard of PICO questions before? Yes, some of you have. Anyone not heard of PICO questions? Some of you. And just so I know, just by show of hands, how many don't like to raise hands?
During talks,
okay,
yeah,
that's
you can
good.
tell.
All right. Excellent. So we have a sense of kind of some of you have heard of these PICO questions and some haven't. If you're thinking that way and if you're thinking critically, as new information comes your way, you start to become a lot more curious of what that information is and what supports that information. And that alone naturally helps bring you more up to date and stay current.
And actually, how do you guys stay up to date? Like, do you read stuff on a regular basis? Do you have, is that there?
Yeah, email research these things.
Yeah.
Table of contents alerts.
Table of contents alert. Yeah, and we'll I don't know how much time we're going to spend helping you with that, but there's many resources, and in fact on our website and on the site for the course, we've got a list of all sorts of really, really good sites that you can go to get information. You can have the information sent to you. And what you ultimately want to find is a group that you trust. And because you can't possibly look at all the information that's out there, and you can't critically appraise it all. And so you need to find a group that puts synopses of this sort of information together.
You can trust us.
Just me. Just me.
Well, irregardless of that.
Yeah, regardless of that, yeah. And it doesn't matter what sort of phraseology I mentioned.
Essentially, our hope is, and we do this with the students that we work with and the residents that come out, our medical residents, so we teach them these kind of skills so that we're hoping that when they see a patient and they incorporate some of this, it helps them solve the problem, but also learn about what's the best approach for that patient in this situation and build their knowledge base and practice that way.
And we think it'll be fun. I know you're going, oh, I'm not sure. But we've had enough experience with doing this sort of stuff that it may not be fun right at this very moment, but in a year from now you go, that was fun. But in regard, and we think it'll make your practice a lot more rewarding. We think some of the feedback that we've gotten from practitioners about this is it really changes the way that they think about their practice. And so we're hoping that that will happen. And so one of the reasons that we have concerns is that, and this is a great quote, and I think it's I don't know how evidence-based it is.
Well, it's one person's opinion.
Yeah.
But it's true that some things go out of style and fashion or knowledge.
Yeah. And so it's your quote, isn't it?
Yeah, so this comes from the dean of medicine over at Harvard several years ago, and I like the quote. He says to his students, my students are dismayed when, or he says about his students, my students are dismayed when I say to them, half of what you were taught as medical students will in 10 years have been shown to be wrong. And the trouble is none of your teachers know which half. So it's kind of...
If we did, we'd probably not say it.
Yeah.
You'd hope, but maybe not, but we all have our biases and so on. But
yeah, there's lots of good, like when I was in school, for example, people taught me to never use beta blockers in heart failure patients, and now they're the drug of choice. When I was in school, we would always have to give menopausal women estrogen. That was just what you gave them, until we got further data that said no, actually, I mean, there's some risk to that, and the Women's Health Initiative. So there's things like that that change what we do and how we do it, and there's being able to kind of critically appraise things and stay up with the data helps you learn about, okay, what's the right thing to do in what situation.
And it's not because the people who are telling you have an agenda. Well, they have an agenda, but it's not a negative agenda. For instance, there's a lot of beliefs. I mean, I'm sure when some of you guys were growing up, how long did you have to wait after eating before you went swimming? An hour? So it was an hour. How many parents told them an hour? How many parents told them half an hour? Yeah, see, your parents obviously didn't love you nearly as much as these other people, right? Yeah, they loved you half as much. Now, the truth be told, there was no evidence either way. But who told you that? Your parents, who love you more than life itself, right? And so their agenda was to keep you safe. But they were telling you misinformation. And there's hundreds of myths in the area of medicine and health. And we won't spend a lot of time on this, but in the area of nutrition, man, oh man, the myths in there are brilliantly good. As an example, and I won't spend too much time on it, how many glasses of water are you supposed to drink every day? 8. This is an amazing nugget of information that you all know. It's not 5 or 10, it happens to be 8. Are you aware of the evidence for that? Yeah. Yeah, it was an offhand comment from a nutritionist 30 years ago when they was asked, how much water should you drink every day? He went, about 8. That's where it came from. There's no evidence whatsoever, but it's a myth that you guys all, I'm not saying you propagate it, by the way, but you know about it. And we'll even do some stuff with like low salt.
Is there evidence to say it's wrong?
No, but actually, well, it depends on how you define the evidence. There's evidence of, from a perspective of people who are training, that it's detrimental. That you cannot train as well, and they primarily think because you've just added more weight. Like if you, and when I'm talking about how much you drink, I'm talking about, when we used to tell people that you should drink a lot of water ahead of exercise. That's actually being tested and not shown to be of value, which is an interesting. So it's not quite the 8 a day. The most where we are now with the research is you should drink when you're thirsty.
Or when your urine's really dark.
Yes, when your urine is really dark. Yes. For all of us who just constantly assess our urine.
Yeah.
My goodness, it's so dark.
You don't look at the color of your urine when it's coming out?
No.
Okay, just check it.
And you know what? Nobody else does.
Really? No. I don't believe that.
No, I'm just kidding. But it's those types of things, and especially in the area of nutrition. I mean, and these things go in cycles. And one of the main reasons is it's very hard to study. So you can just make up whatever crap you want, and people will start to believe it. So that's the important process. And we'll go over some of the beliefs as we go on, and maybe we'll have a fun session on one of the days. I'll go through a bunch of medical beliefs that are not true to the best of our understanding.
So I want to describe the process, so what it might look like for some of you. And we understand that many of you may not do all of this, or maybe some of you do all of this, and maybe some do this a bit more than you're doing it now. We're not kind of sure. But this is the way, if you were an eagle-eyed view of what we're talking about here. Essentially, you would start with a clinical scenario. So that you get that for free without even doing anything. That's the patient who walks into your office, or that's the person you're talking with that says, hey, it hurts when I do this, or this doesn't feel right, or this is the scenario of what's going on. You figure that piece out. So once you've got that little case in front of you, then you start kind of figuring out, okay, how am I going to help them, or what am I going to do? What's that process look like? So I'm suggesting the first piece of that is designing a question. Just prospectively thinking about what do you really want to know? And this really helps if you're going to search the literature, but it works even if you're not searching the literature. So you design what we call a clinical question, and I'm referring to those as PICO questions, and I'll define exactly what's in that kind of question to make it a really solid question to help with your search. Once you've done that, you can search for the answer, and searching could be phoning up somebody, or searching could be looking in the net, or searching could be, you're essentially searching your recesses of your mind or previous situations when you did things, but there's some kind of a search process.
Or even asking colleagues. I mean, there's all sorts of different ways of looking for information.
And then once you've got some answer, then it's essentially thinking back of not just taking the statement for its face value, but actually critically appraising it. So is it valid? Is it reliable? Does it make sense? What's the magnitude? That kind of thing. What went into coming up with that answer? It's the critical appraisal bit. And then interpreting that and applying it and reevaluating, did that help? Did that not help? What happened to the patient? That's kind of the eagle-eye view of the scenario that I'm referring to. And many of us have scenarios and many of us deal with them. And if you break it down to the components, maybe you do something like what I'm talking about. Maybe you don't. Maybe you'll consider doing one or two of the pieces and see if that helps. That's kind of the point of going through that. But I do want to at least expose that in doing this, I realize even with the pharmacy students and the medical students, not everybody takes this on. Some people love this stuff. Some people are champions of this stuff, and that's great. There are people that are close to my heart, that do this, and some,
and most of them have Mac computers.
Yeah, that's true. There's a good correlation, I think. I don't know. But some of them, this is not for them, and so we appreciate that, that there's a spectrum here. And when we ask the people who don't do it, why don't you do it? These are some of the things that we hear. One is, well, I don't really know how to do it. I'm not aware of this process, and I don't understand the critical appraisal bit, or I don't think naturally to make a clinical question. I didn't know I could do that. So it's just a lack of awareness. So I don't know if that's it. Some say, oh, this takes time, Adele. This takes time. I don't have this kind of time. So the way James and I do it, it's pretty quick now. We found really quick ways to answer our questions, and we want to share some of those with you. But time is the thing. There's either not the trial, so I worked in psych and pediatric psych for that matter, and outside of ADHD and the treatments for ADHD, there was very limited evidence for how do you treat bipolar in kids or how do you treat schizophrenia in kids. And some people would say, well, there's not the trials. Why go look for them? Why think of it this way?
And by the way, when we will sometimes shorten when we'll say there's no evidence, what we typically mean, and it comes down to your point, is that when we say there's no evidence about a therapy, we're typically saying no randomized controlled trials. We will clarify that if we're not talking about it, because there is, when we talk about evidence, one of the levels of evidence is experience. And so, but when we say there is no evidence, for a therapy, we are typically saying no randomized controlled trial. And we're not saying that because that's the only way to look at it, but that's what we're talking about, just to clarify.
Yeah, often. But one of the points here is that this isn't a good barrier in my mind that there aren't well-designed trials. There's still information out there that you may still want to access to help answer the question and follow the process. Some people are just not motivated to do it. They either don't have the resources or the incentives to do it. They don't get paid to do it in some way, so that this is not what they want to do. And some don't have the ability to search the literature efficiently. And if you were back in the day when I was in school, we didn't have computers. There was no internet. There was microfiche. Like if I wanted to search things, I got microfiche and I would look it up, and then 3 hours would go by before I could find the book in the library. By then, I was exhausted, right? Like you don't want to, let alone think. Or even when you could do a lit search, you'd get these really long printouts, and you'd be tired. Now it's not like that at all. Like you can find and search and pick up the information all in 10 minutes or less. But
and one of the things that we're going to suggest, we talked earlier on before everyone was here, is that most of you use a stethoscope, I would imagine. Being able to do this is more important than having a stethoscope and using it in today's culture. I mean, you need a stethoscope for certain things. I'm not saying you can look at an article in the New England Journal of Medicine and hear heart sounds. I get that. But if you had to choose which one is the most important to your practice, unless you are doing nothing but listening for lung sounds, it's more important that you know how to do this than many of the things you're doing, because we're so information heavy right now in trying to put it into context.
And speaking of information, sometimes the abundance of information impedes people's ability, or certainly is a reason for, oh my God, there's just way too much, I can't handle it, overwhelms them. So, I guess this is a bit of a rhetorical question, or a question for you to answer for yourselves. What's your hang-up? What's your reason for not doing it, if you're not doing it? And if you are doing it, what are ways you could improve upon how you're doing it? And maybe that self-assessment is something to kind of consider for yourselves.
So what sort of thing, like when you hear the term evidence-based practice, I know some of you just go, coma. But so what are your worries and concerns about it? Is it some of the things we've mentioned? Is it other things? We'd like to know. Yeah, go ahead.
One of the things I've recently learned about is the concept of retraction watch. So something will get put into evidence, you'll see a paper, and then 6 months later, I've seen a few of them, and it comes back and it was incorrect, or there were a lot of biases that weren't accounted for. And so to take the time to actually go through the paper and critique it yourself, that's the part that overwhelms me.
Yeah.
Because I know how much I've done it, and I know how long it took me to do it. And so to be able to go to resources like yourselves, I think would be really valuable for us.
Okay, yeah, no, very good point. And now the retraction watch, you're right, most of the retractions are for people doing illegal lying things. It's unusual to retract, because if they retracted studies that had bias, the literature would be non-existent. So, because there would be none. Because all research has a bias associated with it, and we try to eliminate it by doing certain things. But that retraction is typically the person, for it to be retracted, they've lied, falsified data, and all that sort of stuff. The nice thing about it, now, we probably only catch a little bit of it. When we have thousands and thousands of articles every year and only a few are retracted, that's pretty good. But it's certainly an issue. Go ahead. And I think someone had a comment. Yeah.
Yeah, I was just going to say resources sometimes just aren't available.
The resources.
Yeah, you may think that cognitive behavioral therapy is the best thing to be giving that patient, but there's no resources for CBT in the community.
Oh yeah. So even if you had, that's a very good point. So you may know from the evidence that you want to do CBT, but you just can't even get it. Mm-hmm. Yeah. So that's absolutely a problem.
Yeah. Working in rural areas, or even if it was the best, the patient isn't the right patient to kind of go for it for whatever reason, they can't afford it or
yeah, no, absolutely. That makes total sense. Any other, when you see a new trial comes out, and this is good or that's bad, what goes through your head?
I think sometimes also it's the reliance on the words within the study more so than the statistics. So there's times where I'll say, this was a statistically significant finding, but when you, I don't know, I guess questioning my own view of what the numbers are, it didn't look like it to me. So there's kind of conflict.
Yeah. Right. Do you mean that the numbers look clinically not important or significant, or do you mean like, there was the magnitude of the change was small?
The magnitude looks small. So,
yeah.
So I guess my confusion between what they mean by statistical significance and what that actually should look like.
Very good point.
That's a fabulous, and we are going to cover that, the difference between clinical significance and statistical significance and how they're mutually exclusive. So it might still be very statistically significant, meaning statistically the two things that were found are unlikely to have happened by chance, although it could have. But regardless, even if it did happen because of some matter, it still doesn't mean you'd want to use that drug in this situation or that therapy in this
situation.
situation.
Actually, that's a ton of what we're going to show you is we don't want you to get hung up on the statistics. We're going to give you a very basic understanding of what statistical significance means. We're much more interested in that you guys know how to look at it from a clinical significance perspective and not ignore the statistics because you need those, but statistics is a very, very small part of looking at a randomized controlled trial or any evidence. You need to know and when I say statistics, I mean comparative statistics, like whether a p-value was significant or not. That's a very, very small part, and you just need to know a little bit about it. It's way more important that you have a much greater understanding of what did the study look at and what did they actually find, more so than the statistics. And we'll try and give you that as we go along. Any other things that you can think of? Yeah.
I guess one of the things is with any clinical study or any study that you see, you can have 2 studies for and 4 studies against.
Yeah.
And there's a certain time element involved because, as you said, you're overburdened with a huge amount of data and studies and research. And you start to look at something, and then a year later you have some other data that doesn't support what you think was your conclusion before. So you really, as a clinician, you really have to step back and sort of decide what is relevant, what isn't.
Yeah, and you're absolutely right. So there could be 2 trials that say it works. Yeah, okay. So there could be 2 trials that work and 4 that say it doesn't work. And then how do you deal with that? And there are ways to do that. You can add all the information together, and that's what a lot of people do. And we're going to talk about a group called the Cochrane. How many of you have heard of the group called the Cochrane Library? Yeah, so that should be one of your go-to things, because that's their job is to put it all together in a synopsis that you can actually use in a way to make sense. Is it perfect? Absolutely not. Are there biases? Sure. In fact, when it comes to the Cochrane Library, I don't necessarily always just read the conclusion, because I don't necessarily believe, I believe that they believe that that's what the conclusion is, but I like to look at the actual data that they use to do that. And so, very legitimate point.
And we deal with that a lot when it comes to new drugs coming to market, and we're making recommendations like in the CDEC committee where not all the drugs supported the benefits, and we had to challenge what is the actual benefit. So yeah, having to deal with that is a bit of a barrier sometimes because there's lots of information, and there are tricks that we'll kind of show you around maybe you believe this study more than that, or there's more weighting towards this as they get put together in a systematic review. And often when that happens, some author is really motivated to put it into some kind of a systematic review.
It's a recognition that medicine is not a static science. I mean, it's really, it's changed significantly, obviously, in the last 100 years, and it changes more significantly even within a year or 2 years, because the amount of research and study and information is just multiplying exponentially.
Yeah, no, for sure.
And the process, does it kind of make sense as I outlined it? Like, so are some of you kind of following a similar process to some degree? I see some heads nodding. Okay. So we talked about the clinical question. So once you've got your scenario, one of the first things you might want to do is create a clinical question. And when we talk about clinical question, what I mean by that is a question that has 4 key components. One is, what's the patient population look like? So that's the P part. And essentially it's just what's going on with that patient. Maybe their age, and the age becomes important because treatments for elderly is different than treatments for pediatrics and different treatments in general. Maybe people, women or men, might be affected differently by the particular type of treatment, and their particular disease state is probably an important piece. You know, what disease, what age, what do they look like, have they been treated before, are they treatment naive? Those kind of thoughts around the patient population help identify what kind of information we're looking for with respect to similar studies that incorporated a similar patient population in their study design. Or knowing specifically, for someone that's failed 3 antidepressants, you might try a different therapy than someone who's never had an antidepressant if they were depressed, right? Make sense? So the patient piece is important. The intervention part is something people get hung up on. It's actually the easiest piece of this whole question. And it is really just what you think in your gut is the intervention that's probably most helpful for that person. Right, so it's whatever you think you want to give. If we were doing our oral exam cases, if you had 5 treatment options, the one you think you want to go with, that's the intervention. And it can be whatever you think it is. There's no wrong answer. It's really the intervention you want to give. The comparator is another intervention. Usually it's the gold standard for what typically might be given instead of the intervention you want to give. It could be even placebo. It could be watchful waiting. It could be exercise instead. Like it's really any other potential option that's a reasonable comparator, because we want to know if something is going to be better than something else that you might do. And then the O part of that question is just the outcome. And some people get really focused on outcomes that are important. So does this make people live longer or live better quality of life, or does it cause remission of whatever the disease is? Those are great outcomes. Others are, will this kind of decrease one symptom? Or will this just lower something that maybe is not important? So change a blood value of some sort, or change something that the patient had no real way of knowing is it important to them or not. So asking really good outcome questions and looking then for data of this treatment that you want to give, the intervention, for that patient population to achieve a particular important outcome, that's what we want to see in a clinical question.
And you actually do this every day in your practice. You've got a patient comes in, and you go, am I going to do this? Am I going to do this? And what am I going to look to see if it happened? And so this is very practice-based stuff. It's very formalized, but it's your patient comes in, and I've got a plethora of things I could try. How do I figure out which one? And what are the important outcomes for that patient? And then how do I monitor it? So it's very...
Yeah, it's meant to be intuitive, but if you don't think about it and do it naturally, sometimes you miss pieces of it or don't have the right full picture. So let's practice this, shall we? Does that sound okay? So
what we want you to do, go ahead, Adil.
Yeah. So, and even if you're watching this at home, try to see if you can come up with a PICO question for this case. So I'll read the case out. This is a 25-year-old male who comes to your office with symptoms of major depressive disorder. This disorder meets the criteria. He's functionally impaired. He's got more than 5 symptoms of the 9 that are typically seen with depression. He's had them for more than 2 weeks, kind of thing. This happens to be his 2nd episode of depression that he's had in the last couple of years. In his 1st episode, he tried one of the SSRIs, or selective serotonin reuptake inhibitors, called citalopram, and there was little benefit at that time when he tried that. So that's the information you've gathered for the patient, and now you're tasked with helping the patient out. Before you go to that point of helping them and picking a therapy, you're asked to think of a clinical question. So take a minute and write down the question, and it doesn't have to be grammatically correct, with capitals and sentences and periods like I tell my daughter she has to do in school. It's just say, this is the P, this is the I, this is the C, this is the O.
And you can use phraseology and irregardless in that question. So we're going to just walk around.
Okay. Do we have a volunteer to give us their PICO question? Or even
Or at
the
least
part
the
of
first
it?
part.
Yeah. Maybe someone who hasn't said anything yet in the course. Okay, I think they want you to pick one, James.
I do, right here.
Right here? Okay, well, Eric said something. So
No,
you
no,
mean
Vaughn.
Vaughn. Go for it.
Who's the patient? A young male.
Yeah? Is that as much as you want to put in, or would you add more? That's it. Would anyone else add more? Would
So
they
what would
have
it
the
be?
same?
Current major depressive episode resistant to SSRI.
Yeah. Who's tried one treatment, that was an adequate trial, hopefully, with a reasonable dose. And young male, like 2 years old is young, you know what I mean? Like, we're talking, there's a difference in 10 or what's a young male, so a little more specificity. Again, it's that critical mindset of saying and meaning exactly what we mean. Okay, so that's roughly the patient, I think. So we've got males, and we've got kind of an age piece, and we've got that they're refractory to treatment, and their disorder is depression. Okay, so those are probably key components of your P. So
And it's whatever feature of the patient you need to think about that may help focus that question. P, patient.
or it could
I,
mean-
intervention.
It could mean population as well, but in
Yeah,
this case, it
it's
means
patient.
specifically that patient in front of you.
Go ahead.
These laptop for me was just medication compliance. Are they compliant with what?
Yeah, so there's nothing here to indicate that they are or not. So it could be if there was an issue about patient adherence. If we would have said in a patient who is non-adherent, that would be part of your patient population. There is a huge issue with adherence. Sometimes there's very intelligent non-adherence. In this case, we're not making an assumption either way. Yes, go
And,
ahead.
oh, sorry.
Not making any assumption that there's no new stressor in there.
Yeah, there's no, and the comment is there any new stressor? The purpose right now is to focus whether or not, we don't need to know about the patient. The thing is we want to create the scenario of how you create this PICO. There's a whole bunch of other questions I can see you desperately want to find out more about. Is it, your stressors? Are you this? Are you not? We get that. We're not there yet. That's therapeutics. That's this discussion. This is just literally
Can you
focusing you for a
construct the
second.
question? Yeah.
Any other comments before we go? Yeah, go ahead.
Yeah, I was just kind of along the same lines. Like, is this the point where you ask what occurred with that drug? Like, what were some of the problems, and why did he not get any benefit? Were there side effects? Like, what occurred in that situation? Is that a proper time to ask that?
Yeah, so if you had the detail around there, you had adverse reactions or things like that.
That would be useful.
In this case, for the purpose of this, you would assume they tried and it just didn't work. But those are important things to think about in general. Yeah. And so let's just kind of keep the P the way it is so far, because I think you've described some of the components. We're going to do another practice question after this, which might get into a couple of those. What about the I? What do you guys come up with some of the I's that you'd use? So I means intervention. And so someone who hasn't said anything else.
Yeah, what? Go ahead.
Yeah.
A nutritional assessment, dietary lifestyle factors.
Sure.
Okay, so would a dietary change or a nutritional assessment of some sort be one thing? And what would be the comparator that you might use for that? So the next thing. So I was going on from the I to the C.
Yeah, so you got to so you've got something that you think you want to try, but there is a plethora of stuff. So you'd want to know, is what you're suggesting different or better than something else?
Drug interactions.
Okay, so you want to be more specific with the drug intervention. So you might, right now you might say, I don't know all the antidepressants, so any antidepressant, pick one.
And that's okay.
And that's okay. Or you might say, I want placebo, or if I did nothing, or watchful waiting. That might be a reasonable one. Or one diet change versus the other, so increasing your turkey and milk intake because you want tryptophan in the person versus increasing your caffeine intake. I don't know, but that might be an interesting
By the way,
question.
we're making this up.
Yeah.
You just for example purposes.
But that's, tryptophan, come on.
I was very
Hey,
good
you
actually. I
guys
was very
are-
impressed with that. I was going to add in chocolate
Or
cake.
St. John's wort.
Because chocolate cake would make me feel happier.
That's true. For a while until you got the sugar. No, anyway.
Yeah, we won't go. Yeah,
All right,
that's not a pretty sight.
So there's one. Any other potential other interventions that some of you think?
Yeah, go ahead.
Vitamin D, lab testing for vitamin D stores, B12.
Okay.
So you could look at so you could do testing, right? So it's not just an intervention because you might want to test to refine.
Before you get to
Yeah,
your
yeah.
actual treatment. Okay, so there's a testing of one thing.
Yeah, they're always indoors, right? They're work at night, and they get that seasonal effectiveness from it.
Yeah, so maybe it has to do with light, seasonal effect, all of lifestyle. Yeah.
With a light. So either one of these could be the intervention or the comparator. They're sometimes interchangeable, and for one person they're more interested in one or the other. Let's pretend this is a pharmacological course and think of a drug here.
Yeah.
Yeah.
I didn't have a specific drug, but manufacturing changing dose of the current drug is on.
Changing dose. Yeah,
So
great.
double the dose of whatever. He's not on it anymore. He took it before in his past and it didn't work, so that he stopped it. In the past, he had tried this other drug.
Yeah.
So right now he's drugged less.
But you're right. But it could be increasing the dose is it could be using 50 milligrams compared to 100 milligrams.
And then comparing it to like the
Yeah. So CBT could be a good one. Yeah. Okay.
So you're getting some of the ideas, and there's not one right answer, but it's got to be something that you're thinking of trying or doing that you might implement, and you're comparing it, do I want this or do I want that? Okay, so that's, and what would be the outcomes?
Decrease in symptoms.
Yeah, okay, decrease in general depressive symptoms. Any other kind of outcomes that you might think of?
That's what we measure.
Yeah. So you got to measure it. If you can't measure it, you can't really have it as an outcome. But what some things would you think about?
Activities of daily living.
Very good.
Activities of daily living. Yeah.
Improvements in quality of
Quality
life.
of life.
There might,
The back before, after, seeing if they're.
Affect back depressions.
Yeah,
absolutely.
back scale,
You can
yeah.
do that.
okay. So you get some of that. Let's do
But then there could be other things. What about mortality? I mean, maybe what you're recommending can reduce mortality or increase it. Maybe these drugs increase mortality or they decrease mortality. And there's a whole spectrum of outcomes that will go from death, given that may not be always the worst outcome, but it's pretty a
Suicide's
bad
reasonable one.
No, there are apparently worse on quality of life. Like you'd rather,
Be
I'd
dead than-
rather be dead. But so it's that whole spectrum, and we always have to take into account that whatever we do could positively or negatively affect mortality, all the way down to the very bottom of a surrogate marker that we'll talk a lot about. But you've gotten a number of them.
Change homocysteine levels.
Yeah, change homocysteine levels or change a surrogate marker like that probably has no impact on anybody.
Make my toenail grow faster.
Yeah.
Yeah.
That'd be an important endpoint.
I don't know. It could be. You never know for people. Okay, so let's practice again. Different case.
Eyelash color. I'm thinking, and that's what you guys are all about. We know, yeah. Okay, so here's another one.
So again, take a minute and come up with a PICO for this. I'll read the question for you. This is a 56-year-old female who's got a 5-year history of type 2 diabetes, and they've come to your office. Her family physician had put her on metformin at a dose of 500 milligrams twice a day. And if you're not aware of the metformin dose, that's kind of middle of the road. Usually max out at 2 grams, and some people start out 250 or 500 twice a day, so it's kind of middle. Her hemoglobin A1C was 8.5, and at least that's what she remembers her doctor saying. And she is actually interested in having some natural therapies, and that's one of the reasons she's come to see you. So she wants to know what should she do. So this is your clinical scenario. Again, that's given to you for free, and the next step is you guys have to start thinking about your clinical questions. So you may have a whole bunch of other questions about this case. Make some assumptions in your mind and answer those questions in general if you want to know one thing or another. But come to the point where you can design a clinical question. And so hopefully you're doing this while I'm talking. I'm just kind of killing time while I'm talking. But the thing to think about this is you may get a case in your, I'll get to the question in a second, in your oral case. And in that oral case, you'll have been given the scenario. We might ask you to develop a PICO question as part of that case. So before you start talking about the goals of therapy and all the other things, we might say, what would your PICO question be for this? So in case you're wondering about, hey, Dale, how are you going to examine me on this at some point? This is how we've used it in the examination process. There could also be a multiple choice question about this, but that's it. So Jody, you had a question.
Just has she started the metformin and it's still
Yes.
at 8.5?
Right. She started it and she's at 8.5. She thinks she needs to do something. Well, maybe it was at 10.5 and now it's 8.5, so maybe it was effective. But maybe she's wondering if she...
Like it's not, she just went in and got this, because that's...
Right. She didn't just start yesterday. She's been on metformin for, let's say, 2 months. So obviously you may not be writing PICO questions out. I mean, it might be neat for some of you in your charts to say this might be the PICO if that's a strategy change, and some people have told me they actually do that. But intuitively, as long as you're, okay, categorizing, this is the patient, this is the intervention I'm interested in. This is the outcome. Just going through that practice. We're doing it at exhaustive lengths right now, and you might do it more subtly in your practice. At least that's the seed we're trying to plant.
That still has elevated hemoglobin A1C, so we need to address the elevated blood sugars.
Okay. Is that it, or more?
That's it
For the people. Ah.
One more thing.
I was going to ask, yeah, who's on metformin, right? So, it's important to say what treatment they may be at, because obviously by saying that means your intervention is not going to be metformin, right? But, well, that's wrong. You could increase the dose as an intervention. But I meant, okay. Yeah. Thank you. Sorry, I'll shut up now. Intervention. Do you want to keep going with the intervention, or shall I toss it on? Okay. Somebody give me your eye. How about Sandra? People who aren't looking at me, I usually go.
They looked up. Is that me?
Is
It
that
was.
Sandra? I think I'm Sandra today. Yeah.
You were hoping.
For the intervention, I would ask her to do a diet diary.
Okay.
First to have an idea what her diet is like. Start talking to her about high glycemic index, foods, decrease in sugar. Like it would all depend on what, her current diet.
So the intervention is a diet change of some sort, which involves the tool of a diet diary, so they know and you know what they were taking. But it's the intervention specifically is a change in diet.
Exactly.
And different tools. Okay. What would be a comparator for that?
It could be, using more minerals such as chromium, or having her have more cinnamon, or other supplements, fenugreek, other supplements.
Like cinnamon buns?
Natural.
Not cinnamon
I like
buns.
that intervention.
Yeah, cinnamon buns for diabetes. I know what you mean. Okay, so I don't understand how that comparator is different from your intervention, because your intervention dealt with a diet therapy,
Well,
and
I
this
guess
is diet specific.
within the dietary therapy, there can be so many things.
Okay, so then I think it's important that you say this dietary change versus that dietary change, if you're not going to do both at the same time. Because when you said dietary intervention, I think that encompasses this is now how you might eat, and this is what you should do. But if you're saying, I might make them do...
Considering supplements.
Yeah, so it's one supplement over another. Okay, fair enough. Thank you for clarifying. Laura.
My comparison would probably be metformin alone over a period of time for the HbA1c measurement versus the natural therapy in the same period of time effect on HbA1c.
So they're already on a dose of metformin. So he's already on metformin of some sort. So do you mean a higher dose?
No, sorry. So comparing what the effect has been of the metformin
Yes.
as is, and then versus what the added effect is of the natural therapy.
So, okay, I'm confused.
Yeah, no, so what you, so I know why you're confused, and the reason that you're confused is because what you have to do is you have to think about that they're already on that. So that can't be what you're doing. So you're not going to compare what they're already on. So because you got to do something different than what they're already on. So what was your intervention?
So we'll say removal of simple sugars. I meant so doing that for 2 months and seeing what the effect is on.
Yeah. So your intervention would be removal of simple sugars, compared to not doing that. That your intervention could just be not recommending it, or it could
So
be
watchful waiting, maybe is what it is.
It could be watchful waiting, or it could be a medication, or whatever. You need to have a comparator to see which one's better. Because let's say there was a study, I don't think there is, of what you've just suggested versus another drug. And let's say the drug was way better, or let's say the drug was way worse. That you need to know the answer to that. So the intervention isn't what they're already on.
In most cases.
The intervention is that plus.
Yeah. So we're always adding on. But we already know that because the patient. That's part of your clinical question, is because the patient's already on metformin. Go ahead.
What if the patient's hemoglobin A1C 2 months ago was 8.5, and now it's still 8.5? Could you take them off the metformin, and then it would be a comparator?
Oh, yeah. I was just going to say when he said it's always adding to them, your comparator could be removal of a drug,
Yeah, absolutely.
or removal of something.
Could be stopping it because it could be causing it. Not in this case, likely, but.
But essentially, you have a choice of doing two things, and maybe your second thing is a choice of being inactive about doing something, but it's a choice not to do something. When you're doing your PICO, you're being very articulate about that. So let's hear a couple more I's and C's and maybe some drug-specific stuff.
Wouldn't it be, for naturopathic doctors, wouldn't our comparative generally also want to be what the sort of gold standard or standard conventional treatment would be? Like, would we want not, like in our discussion, so like in this case, maybe either increasing the dose of metformin using like sulfonylurea or something else?
Well, that's not.
that, like, isn't a comparison a point of if you're diverging from sort of what a standard treatment would be?
No,
It's just
it's not necessarily divergent, because that's why we want to get you away from thinking that there's drugs and then there's other stuff. It's all treatment. And so the treatment is, if you're going to recommend a physical activity and an improved diet, if I was to do a clinical question for that, here's what I would say. In a patient, is this dietary recommendation and exercise, is it, compared to not doing it, going to make a difference?
So shouldn't your comparison always include what the standard?
Or the gold standard. Yeah, I think you and Eric are saying the same thing.
Yeah, it doesn't have to, because oftentimes it could be does this antidepressant compare to this antidepressant, and neither of them may be this gold standard. It would be nice to be the gold standard, because we want to know if the gold standard, if what we're trying is better than the gold standard. But yet, no, so I think you're...
Yeah, so sulfonylurea would be a reasonable comparator or intervention compared to something else that's natural or otherwise.
Yeah.
That would be a really good one.
Yeah.
Or comparing one of your therapies to an increase in dose in metformin.
Anything else? So again, there's a multiple. There's probably 10 medications that could have gone in this list, and there's another 10 non-medication things that could easily have gone in this list, and they're all correct. If that makes sense. Yes.
I just have a question. I'm not sure where this fits in PICO.
Is it a clinical question?
Yes.
Okay.
Well, we're a little judgmental, aren't we?
So, knowing that hemoglobin A1C is an average,
Yes.
wouldn't you want to know what's happening on a daily basis?
Would you?
Would you?
I would think so, because maybe there's a pattern going on.
Right.
Yeah.
Well, we will. So the question is, do we not want to know? Given that A1C is an average, don't we want to know what's going on day to day? We're going to spend a lot of time talking about the treatment of type 2 diabetes later on, where we're going to deal with those specific issues. It's good that you're thinking about them. We're not to the area of therapeutics yet. It could be, but as an example, a great question, and actually we have really good information in this. Does, in a patient who has type 2 diabetes, does measuring their glucose compared to not measuring their glucose make a difference in outcome? And you know what? It's worse if you measure it.
But,
so that...
Well, it depends what you list as your
so
outcome.
Depends what your outcome is.
People think it is, so we'll...
Yeah, so we're going to get there. So, but a testing could be part of your intervention, in theory.
How does testing happen?
So what about your outcomes?
Just to go back to intervention, I'm a little confused. Like, in my practice, when I see somebody with diabetes, I don't just look at just nutrition.
Yeah, we just like that in
or
a preferred framework, I feel.
We get that, and what we want you to do is blend the way that you're thinking.
But can we blend in, like, say, test for amoebas, which are kind of diabetics?
Sure. So you could.
That will come up in research.
Why? Why not?
It's not that often.
Yeah, it may not come up, but wouldn't it be brilliant if it did?
Oh, yeah.
Yeah. So just because you go.
It doesn't have to be thinking like it doesn't have to come up frequently in research. We can still plug it in.
Sure. But then what you would do is you go this, because the next step is to look for the evidence to support doing it. That's the whole point of doing the framework of the question, is to then go, now I've got to go find out, is there any evidence, all the way from randomized controlled trial to clinical experience, that supports what I'm doing? We're framing the question. The question has nothing to do with whether there's any evidence. Wouldn't it be nice, though, to answer the question if we had some evidence for it? Is that where was that the twist that you were missing? Or?
Yeah.
I think part of it is that we probably all in the room do this on an intuitive basis without putting a framework or model to it.
We realize that.
And so just sort of knowing where it's going, I think was the piece I was missing.
Yeah, so we're going to try and, we'll do a number of these to try and get you framed in the right place.
So you're saying we take this and we then apply it to
anything,
like formulating the answer.
Yeah. Well, but isn't that a great learning thing if you did it? So for this patient, would doing this instead of that result in a better likelihood of this outcome? And is there data to support that or not? And maybe you search literature, maybe you talk to another colleague that does it who knows it or not, but you're searching for now, you've got something that you've prospectively planned and thought about. You're more likely to learn about that and create a better decision for the patient. Yeah. And just to add to something that James said, if there's a lack of evidence, we're not saying that means there's a lack of effect or that we don't know if it works or doesn't. We're not making that statement at all around that, or lack of evidence suggests a lack of benefit. Like, no, but knowing that there is an evidence gives you the sense of, hey, I'm working in an evidence-free zone here, versus maybe there are things of evidence that does support this over that, and learning about that might be good for you and the patient. Go ahead, Process.
So I'm just confused, because you said that on the exam we could get a question.
Yeah, and you will get tested on this concept, so we will. Let's take the time to be clear.
With the interventions, you just want kind of a single treatment listed?
Ideally.
It's just chromium versus diet, exercise, and supplement? Because that's usually in our practice, that's what we do, it's combined intervention, not just a single agent.
Yeah, but remember, a combined, so don't get hung up, because a combined intervention could be your intervention. It could be doing this and this and this and this and this compared to this. But the problem with that, it's not, I don't know if it's really a problem. The problem is, if you do this and this and this and this and this, which of this and this and this and this and this and this made a difference? You can't know.
Right.
So
that's what I mean. So when we're designing the question and intervention, like if we're on the exam, we're kind of stepping out of how we potentially be thinking about it with the patient sitting across from us. We're more designing it from kind of like looking at how the evaluation is going to be in terms of outcomes. Sure, yeah. Just with single agents.
Yeah, but
more how we evaluate drugs.
Yeah, and this does not just literally apply to medications, in my opinion.
No, I'm not saying it does.
Okay.
From an exam point of view, you would not get doctor mark in this setting if you said, how does improving or lowering simple sugars compare to adding chromium to their diet? Those sound like two different things that you could do, and as long as you had a good outcome, you could get marks for that. As well, because we're trying to train you to think pharmacologically, you would be just fine. And even though you may never use either drugs, you would not be docked for saying, how does adding a sulfonylurea differ from increasing the dose of metformin, or adding a DPP-4 inhibitor, one of the gliptin-like drugs, one compared to the other. I'm curious about what would be better for a particular outcome. Both
Go
ahead.
And then in terms of outcome, then you're generally looking for like a lab test or something.
Well, we're going to go. So it's the
What would
floor
your
is all
outcome?
the floor is all yours. What's the outcome?
Well, I mean, an obvious one would be hemoglobin A1C.
So one of the outcomes is hemoglobin A1C. What else?
But then we'd also be looking at, energy level for the patient. Has their
Energy level?
appetite change?
Appetite
Have they
change, what?
lost weight? Is their cholesterol change?
Neuropathies,
Yeah,
cholesterol.
all that kind of stuff.
What else?
Hypoglycemic reaction.
Hypoglycemic reaction.
Hypoglycemia, sure.
Yeah, another therapy.
Anything else?
Anthropometric measurement.
Anthropometric measurements. Yeah.
What is that?
Waist to hip.
Weight.
Oh, yeah, sorry, okay, yeah, okay.
Yeah.
So it's getting fatter.
Yeah.
Okay. Are they
Same
getting
thing.
fatter?
It's getting fatter. That's the medical term.
You got to think simply to me here.
Yeah. And we're going to spend some time talking about that evidence as well, if you want. Because go ahead.
I just want to be clear, we're taking out the individual out of this picture. Even though it's about a person, we are taking it out of context. We're not sitting in front of the patient and it's like a study of like...
No, because this is going to be so if you got this patient in front of you, I'm assuming, maybe I'm mistaken, that your thought process goes, I'm going to do something different than what they're doing now. I'm sure that must be what you would do. I've got a patient. I'm going to recommend something. I'm going to do...
No.
You wouldn't recommend anything?
Not necessarily. First you listen.
Oh, absolutely.
You have to, the information will come to you, but
Yeah.
you have to listen and the person is an individual, and from there, you then start to understand where you have to go.
Absolutely. Well, we are all over that. And in fact, you guys do that brilliantly. And that's a very important part of data collection, and it's very individual. That's where the whole patient preferences, patient's values, patients comes into. So we're all over that.
Maybe I'm just having difficulty because I'm having to just theoretically paint a picture now, even though I can't start digging into the case to understand where they're coming from.
Yeah, we need to know all that, and we will get into some of that. This is very more black and white as we're talking, and it'll make sense, a little bit more sense as we go along. But we've got some outcomes, but
and it's normal to feel a little bit confused for some of you
Yeah,
if this
I get
doesn't.
it.
This is a new kind of way of thinking of things, and it's different. So it's even just being critical of kind of, in a good way, critical of kind of, hey, does this make sense, or how will I apply this? Those questions are much appreciated because it tells me that you're trying to see how do I fit this in? Am I going to fit this in?
Go ahead.
So that's really good.
I'm having a difficulty just with sort of plugging in sentences into this little grouping of words, because when we talk about intervention, are you looking for sort of the questions that we would ask? Are you looking for something like,
Not the question.
you're looking at comparing chromium versus diet, or are you
Yeah,
actually looking for
that would be
the
that would be a great one. So in this patient, does giving chromium versus making a dietary recommendation, is there a difference?
So it's almost like we're writing a little research proposal.
We're not actually putting the in that we're going to test their glucose or their A1.
Well, it could be. We don't want you to get. We don't want you to come away from this going, this is just for research perspective, because it could be, like I said, testing glucose in this person. Like, you're going to test it, but do you know if that improves outcome? Because if you don't, it may worsen outcome.
Well, it's a baseline for which you need to compare to so that you can decide whether they've improved outcome.
But actually, and we'll get there in just a minute because it's important. So you guys have mentioned a bunch of outcomes like A1Cs and some quality of life stuff, but what are the key outcomes that are missing? Yeah, so why do we treat that type 2 diabetes? Yeah, so your outcomes are not, A1C is not that important of an outcome. The important outcomes are blindness, renal problems, cardiovascular problems, neuropathies, cancers, infections, all of those things. Those are the most important outcomes.
But it's short-term, long-term. I mean, short-term.
It may be short-term, long-term, but you need to know that your short-term affects the long-term outcome because it may not. So that's the important. So we want you to focus on those really. So when we say outcomes, we want you to flip the order of your outcomes. And we know you guys think this way. It's about the patient outcomes, not the lab outcomes. The lab outcomes are the least important unless they are unbelievably correlated and associated with a good outcome as far as death.
But isn't most of the drug trials based on lab outcomes?
The question is, aren't most drug trials based on lab outcomes?
Improving A1Cs?
Yeah, and so many of them are, which is why we don't focus on those ones. When we're going to talk to you about outcomes, we will, most of the time, not spend a lot of time talking about the trials that look at those outcomes, because those outcomes have in a nice way, screwed us in a number of circumstances. So if that's the only outcome that you have, then you have to use that as that's all we have. But I much more care about, does it affect mortality, heart attacks, strokes, kidney failure, eyesight, neuropathies. All of those things are way more important than a measurement of a lab value. That is one of the things that we really want to get you guys thinking about. You probably already do, but even more so.
Okay. So don't worry if you haven't grasped the concept of a PICO question yet. You'll get time to practice, and even during lunch, if you want us to individually work with some ones, we can come up with some cases and you can practice it between. Like, you don't have to master this concept today. There's a reason this course is 4 days long, and it's for us to practice different things along the way. So as long as you're getting a sense that this concept exists, it does help if you are formulating research questions, and you will see when you look at some of the synopsis that we will show you that they've asked a clinical question, they've answered it, and you'll be able to kind of realize and hopefully resonate with what question they've asked and how well it connects with the kind of patient you have in front of you. But at least you understand that there's these components, and you have a sense that it's a way of thinking of kind of how do I move forward when I want to start something in a patient, and we'll go from there. We talk a lot about what we call therapy questions, and I want to just mention that there's questions we have around, is this diagnostic test better or is that diagnostic test better? And those often don't use necessarily randomized controlled trials. We talk about, is this medicine worse with respect to adverse effects? And sometimes there's different trial designs like cohort designs and case control type of designs that help inform those. Sometimes it's not ethical. Like if I wanted to know if smoking made someone die faster, I wouldn't do a randomized control trial and have half the people smoke and not smoke, right? But I still want to know about that question. There's other trial designs that help inform that. We're most interested in therapy questions. Is this treatment option or intervention more better than that treatment option or intervention or placebo? Or we want to know that. So we often turn to these randomized controlled trials.
Yes. But as we've talked about before, randomized controlled trials are not the be-all and end-all of evidence. You don't need a randomized controlled trial of parachutes
To know they work.
to know they work. But there is a category in the levels of evidence that's called all or none. And it's the highest level of evidence. And it's if you always die or you always get something, and every time you use something to affect that and it never happens, that's the best evidence you can have. That's the highest level of evidence. So, and this is a little bit of it, but you almost always die jumping out of an airplane without a parachute. Most of the time you don't if you use a parachute. That's solid evidence, and it's in the hierarchy of evidence.
You don't need to go beyond anything there.
You could go to a randomized controlled trial. Ethical, getting consent would be a tad tricky. And as Adil said, smoking's the same way. We can't do it. But we now have overwhelming evidence that smoking is bad for you. But you do know that the tobacco companies, and this is how they distort the concept, is that they went and they said there is no evidence that smoking is bad for you. And when they said evidence, they meant randomized controlled trials. You know, that's paraphrasing a very large argument that they had against the concept of evidence. But that was and that's how you can use evidence in an absolutely inappropriate way to make your point. And do you see where I'm going with that? So that's why we're not, when we were asked the question, are we hung up on randomized controlled trials? No. But boy, they're useful for some things.
Okay, so you'll hear us refer to randomized controlled trials, and you'll often see that we're referring to what's called a systematic review. There are different types of review articles. Like if James and I want to review a topic, we might just go and I might do a bit of a search and find articles, and we would just write a narrative review. That's not necessarily a systematic review. When I talk about systematic reviews, I mean someone that's explicitly gone out, had criteria for articles that they want to include in their review or exclude, and then analyze that information in such a way that's systematic and rigorous. And so just know that we're talking, and that's essentially what a Cochrane review is. It's that kind of systematic review versus just what someone might refer to as a systematic review, but not actually do a systematic process. So sometimes you have to check what did that review look like? How did they collect the information? Did they look for unpublished data and that kind of thing? So know that we will look for that kind of stuff and give you systematic reviews. And we'll often use the term systematic review and meta-analysis interchangeably, even though those words are not interchangeable. Meta-analysis only really refers to a statistical process done when you put a whole bunch of lab values or outcomes together, and when you analyze that data and then come up with a particular odds ratio or a particular level of benefit. And so that's the statistical process of doing that is usually done in part and parcel of a systematic review. And if the systematic review is done well and incorporated similar trials with similar interventions and similar outcome measures, it's deemed to be relatively homogeneous or not heterogeneous. That we'll talk about these things called meta-analyses and systematic reviews. And I assume you know what those are, given my brief description, and that's fair. If not, those are typically things that we'll look at, and those are usually reviews of randomized controlled trials to answer the kind of therapy questions we're going to give you.
Yeah, because there was a comment made earlier, well, what if there's 2 trials that show positive benefit and 4 that don't? Well, there's a way of combining that data, if the trials are similar, to give us the best assessment of whether or not we think something works. Or, so if we've got different results, or if there are studies for which they don't look at things like mortality. Because to see an impact on mortality, you have to study thousands and thousands of people. And so what often is done is you take a number of smaller trials and put them together and then try and get to see if it has an effect on mortality or heart disease or strokes or whatever. Because to do that, you need to look at thousands and thousands of people typically to see if there's any impact at all.
Okay, so you've got your clinical scenario. That's, let's say, the 56-year-old patient with diabetes. She's come in and she's on the metformin, she wants some therapies. You've come up with your clinical question. I wonder if adding chromium is better than increasing the dose of metformin to see if they live longer or to see if it makes them have less cardiovascular events. once you've got this question, you want to seek an answer to the question. So you can go to many different places. You might say, hey, I've got these textbooks at home. I'm going to look at my textbooks. You might know that there's journals out there, and you can search some of them. Or you might recall, hey, I think I remember a journal that looked at that particular question or looked at a piece of that question. You might phone a friend. You might say, hey, Paul, I know you're into this kind of stuff. Let me call you and see if you know the answer to this. Or you might phone, connect with another expert. You might go to Cochrane, you might go to Medline. There's lots of different places you can go, and we'll kind of show you some. There are some evidence-based journals that write synopses on these kinds of things, so I turn to those a little quicker because they give me answers a bit quicker. And there's some really good websites that you can go to. And on the websites that we've been given to you for the course, there's links to some of these kind of places you can go to answer some different clinical questions that you have. So know that they're there, and know that when you are searching for information, you might get back people's expert opinions. You might get some non-comparative case series or cohort trials, or you might get the RCTs. And whatever the best available evidence is, well, that's the best available evidence. You've gone, you searched for it, and you now have this hierarchy. And maybe you might believe the results here a little bit more than the results here if they exist, because in theory, the process here should have removed some of the biases that might have naturally creeped in here. Okay, and that's the reason this kind of hierarchy exists.
But it's important to realize, and I'm using extremes to make my point. So guess how many randomized controlled trials there are of general anesthesia? None that I'm aware of anyway. I mean, there may be randomized controlled trials looking at different induction agents and things like that. But you do one, right? Can I take this person's heart out without anesthesia? There's a lot of complaining. But if you have general anesthesia, it's a lot easier. It may not be perfectly safe. You don't need a randomized controlled trial of general anesthesia. And general anesthetic drugs are drugs that are phenomenally effective and are really one of the key, I think, advances that we've had in the last 150 years in medicine. You don't need an RCT for that. But what you want? Expert opinion. Because you're going to have a person who's used chloroform when we first started using it. We want that expert opinion. It's vital. If you break a leg, I don't need a randomized controlled trial of do I make sure the bones are, do we set it properly or not? You don't need a randomized controlled trial of that. So we're trying to make sure that you realize we don't think RCTs are the be-all and let's say I have a study that shows Tylenol works for migraine headaches. Let's say I have a study, which there's lots. If you have a migraine headache and I give you Tylenol and your headache doesn't go away, what should I be saying? Well, no, it has gone away. I have a randomized controlled trial. That's ridiculous, right? They give you an antidepressant, yes. Yeah. Or an antipsychotic, because clearly she's insane. So we can have all the randomized controlled trial data in the world, but if I give it to you and you don't respond the way I want you to, who cares? Do you see where I'm going? But when you're talking about things for treatment of diabetes, blood pressure, cholesterol, and so on, the only way you can ever know if those interventions help is with a randomized controlled trial.
Help in general.
Yeah, there is no other way that you can actually tell. Now, you can tell quality of life in a patient, but you'll never know. And we're going to talk a lot about that when we talk about cardiovascular disease, because the only way you can tell if any of these interventions is to do a randomized controlled trial, at least the way I think about these things.
So I've given you suggestions of where you could go, and just if it helps, I'm suggesting now where I go. So I often think of clinical questions when I'm in situations where I'm faced with, okay, what do I do? Do I want to do this over that? And I'll often go to evidence-based journal abstracts and commentaries. So there's this thing called evidence-based medicine, and they give you a one-page, only one page, like 3 paragraphs. They tell you what their clinical question was, and usually they'll have reviewed the literature and say, based on that literature, this answers this clinical question, and this is the answer, and what supports it, how much. And I know that these guys they've got a really high sense of critical appraisal when they're forming this paragraph. So I know they've done a lot of the work, and they're giving me a sense of the effect and the magnitude of effect. And I then will take that piece and be able to wonder if it'll apply to my patient or not. So these things that are synopses are easy to digest. They're easy reads. They're very efficient. You can get answers to some of your clinical questions in 5 minutes or less. If you want more detailed information, there's places you can go to look at it, and they give you really a nice summary. So where are the exact kind of places? I don't know if any of these titles mean anything to you. Info poems, does that mean anything to you? It's a Canadian thing that most physicians that are part of the CMA, so medical physicians, they get these things naturally sent to their inbox. Again, they're like one-pagers. There's clinical evidence online. There's the evidence-based space I talked about. A free place is Bandolier. If you're interested in pain management, they do a lot of great clinical questions and answers to clinical questions, and they have a similar style to James and I in that they're a bit humorous in how they answer it. We've referred to the Therapeutics Initiative, ACP Journal Club, something you pay for, but they also review different articles. Tools for Practice, that's something our friend Mike does, the family physician that we refer to, and there's links to that on your course website. There's many places to find the synopsis. Now, it's hit and miss. You may or may not find the actual thing you're looking for, but if you do find it, you've saved yourself a ton of time. And if it's an important question, often someone's gone and solved this question for you. In fact, I'm quite delusional, speaking of insane, in that I think there's a whole bunch of people out there working for me to create all these different synopses, because every time I have a question, I can usually find somebody who's answered that question. And if not, I can usually motivate someone that I know to work on answering that particular type of question, whether it's in a therapeutics initiative or otherwise. So I encourage you sometime between now and maybe the next 2 weeks to look at one of these places, hit one of the links, if you've come up with a clinical question based on a patient that you've seen in your practice, to just see, can I answer the question or not? And if you want, during the break or otherwise, we can just open the internet. You can give us a sample question. We'll come up with a clinical question, and we'll see if we found the answer. I'd say 50% of the time, so not 100%, but 50% of the time, we'll probably find a quick answer to the questions that we have in our medical pharmacology area. I don't know if that's the same. I've not really done this with natural health products, but I'd be curious to see how well that is. I saw a hand up there.
Are there any particular ones that are more CAN-friendly than others?
Well, Paul, I don't know, Paul, if you want to comment on that.
Sure.
There's not a lot, but one of the things we want to break down is the barrier of alternative versus. There are two types of medicines. Medicines that are being shown to work, and medicines that may or may not work. That's really where we are, I think. And when I say work, that could be depending on how we define work and how we define evidence, and so on. So there are some, but much of the stuff, like many of the supplements that you guys may use, that actually many people use, there are lots of randomized controlled trials of this stuff. Like there are hundreds and hundreds of studies, like of omega-3s and vitamin A's and vitamin E. Pardon me?
Why is it not being incorporated?
Into what?
Into standard practice.
Well, some people value them and some people don't, based on the different types of evidence.
Why is the evidence not being incorporated? Why omega-3s?
For example, the evidence for omega-3s is earth-shattering, is huge, and yet...
In what way?
Pardon?
Earth-shattering is that
that's one of the not very specific terms. So
I understand, but I'm not going to get into specific terms now, but there's pretty strong evidence from what I've seen. Lots of RCTs, lots of solid evidence, good sizes, in good journals, that for example, CoQ10, essential fatty acids, and it would appear that it's strong enough to be used sort of by the standard medical system, yet it's still not.
That's an interesting, maybe we'll get to this, but I thought at the end you were going to say, and with omega-3s, there's clear evidence of no benefit.
You need to know the outcome.
Yeah,
you need
we
to
got
know
to look at the
disease state.
That's a really
and
important.
What's the actual outcome of interest that's happened, and
Because the best
what's the
available
magnitude
evidence.
of effect. But let's search some of those.
Yeah.
We could go through one, why don't you just go on the third one right now, because if you search...
Like Bandolier?
Yeah.
Are you on Bandolier right there?
Yeah, if you go to that one, like if you go to back pain, for example, and it's got a whole list of questions. So what works for back pain? It's got acupuncture for back pain specifically. So if you click on that, it's got the whole... it's got a synopsis of the results,
Right.
the chart, and the number of blind studies, the number of non-blind
Right.
studies, and the numbers there. So so it is in some of them. I think you just have to.
Yeah, and it's a matter, and you actually have to. We wish, what we'd love? We'd love to say this is the site. It doesn't work. Now Cochrane is very good for that, but it usually requires a subscription unless you have access to a medical library and so on and so forth. But
you want me to go back? I'll just do glucosamine because that's something that I think they would have. That's good.
But even to the alphabetical listing, like if you click on anything.
Yeah, oh yeah, like, you can kind of search different things here if you wanted to know different things. I guess really the point of this is a sense of how would you use this tool. Let's say your clinical question was someone who had arthritis and you're wondering about glucosamine versus acetaminophen. They'll kind of give you a quick synopsis here. What do they say? As many as 1 in 5 patients with knee arthritis will benefit from using oral glucosamine at this dose. The number needed to treat. You'll hear us talking about what that means.
We'll get to those numbers in a minute.
And reduce joint space narrowing. So here, this is an interesting thing because what outcome do they pick? Reduce joint space, right? So this is the number needed to treat for that. How many patients do you know that walk in your office and say, my joint space seems to be a bit big here? Can you reduce that by a certain millimeter amount? They don't, right? You want to know that I got knee pain. How much does my knee pain reduce?
Yeah.
So if that was your outcome in your PICO question, you wouldn't look at this as much. You'd say, you can quickly discard this. You might look at it because you're interested in it, but I'm looking for that study that says knee pain went down by 50%.
Yeah. And in fact, I think in this case, I may be wrong, but I think, and by the way, I think
This was an RCT.
Yeah, this is an old review. There's more data that's come out since that time with glucosamine. I think the first comment refers to pain control, and the second one is to do with the 4.9 has to do with pain control. The space, which is
Well, maybe they're looking at more.
But go ahead.
There's one here for fish oil for RA.
Yeah.
Their findings were at 3 months. Fish oil resulted in significant reduction in tender joints by count of 3 joints and reduced morning stiffness by 26 minutes.
Yeah.
So
Right.
it would be
So, but
appropriate.
and the point around this is more synopsis, right? You got a question. Where can I go to get an answer that's easy to digest, quick, evidence-based, and help inform your practice without searching for hours?
And so what you want to do is most of you will have typical patients that you see. So if you typically see diabetics, if you typically see patients with arthritis, you should have at least a reasonable knowledge of the evidence that's available for whatever it is that you're recommending. That's what what we'd encourage you to do is, starting today, is do 1 a week, 1 every 2 weeks. Just go have a quick look and see what's available out there. What we want to do is give you the skills so that when you look at it, you don't go into a coma and go, I don't get it. Because I've seen that happen all the time with many healthcare professionals. Is that and by the way, if Adele and I can do it, there is nobody in the room who cannot. And I truly mean that. It is not difficult once you have the tools to do it.
I'm just showing the tools of practice.
So tools of practice is a really good example of, it's a 300-word synopsis on, just click on, I don't know, Mox or whatever, it doesn't matter which one it is, but there's some really good questions. And just Google should be your friend. That's the very first, I search Google right away. That's my go-to search thing right away. And and as being said, your patients do it as well. So you may as well know how to do this because they pull up Google? Really? Yeah, here's that's another sort of the comment. Well, most of the stuff you find on Google is crap. Really? No, that's not
evidence-based.
That's not evidence-based at all.
Or,
they say it's wrong or whatever. Well, really? New England Journal's on Google. The Lancet's on Google. I got a website on that you can find on Google, and
that one might be crap.
That one is crap. But it's not that Google is crap. It's that there is crap information out there, but there's absolutely brilliant information out there that we have access as healthcare professionals, and so do your patients. And boy, oh boy, you better be able to do it because they're getting pretty good at it. What they may not be able to do is know what is good, and they may not know how to think about the evidence that's out there.
This is just, again, the point around this is know that they exist. It's hit and miss whether you'll actually answer your question or not. That's why I gave 50%. It's not 90%. You can't go out there and you'll be disappointed. But depending on your question, and maybe it's higher in my world, in answer to your question, there's a thing that I now have access to. It's called Natural Standard. I don't know if you've heard of that. Some schools have them. UBC just signed on to it, so we have it there, and some of the health authorities signed on to it. So I found some. Okay. So I don't know if that was helpful or not, but I thought they tried to incorporate some evidence-based concepts in their reviews. I mean, you'd know more about those topics than I would, but at least I thought they tried to incorporate the principles that we're referring to as they did.
Just so you know, have you heard of guidelines? I'm sure you have, because it was a rhetorical question. It was just to get
No, I haven't heard that term before. I've heard of irregardless, but not guidelines. Yeah.
So irregardless of whether you've heard of guidelines. So guidelines, when you look at the evidence to support guidelines, of all of the recommendations in guidelines, only 10% are based on randomized controlled trials. 50% of guideline recommendations are opinion. Purely opinion. And that's looking at cardiovascular guidelines and infectious disease guidelines. And so what's really important for you guys to realize, and by the way, if you go searching for evidence and there is none, that is brilliantly useful. Because now you know there isn't any. And so you've got to incorporate that into your process of what do I do when there's absolutely no quality evidence like randomized controlled trials when there isn't any. How do you think about that?
You'll be happy to know coffee is okay to drink. I just double checked. Doesn't really help mortality-wise, but it doesn't hurt. So this, the author of this is, if you're listening to any of the podcasts, and there's lots of links to podcasts that are available at Tech, that Mike is the Mike that helped write this and is involved with this. So.
And what they do is they take questions that are relevant to their general practice, and they try to answer them with the best available evidence. Realizing, when we say the best available evidence, it could change tomorrow. There could be the best trial ever done that completely reverses what we thought. It's unusual that happens, but it could.
So we're going to spend about 5 more minutes, and then we'll have some lunch.
Yeah.
Right. Okay. It's just so you have if your tummies are wondering what. Whoa. Why did it do that? So write a clinical question on that one. Why did the computer just stop? So the next piece is just around trials, okay? So let's say you've got a scenario, you've asked a question, you've started a search, you really didn't find a great synopsis, but you found a trial that's out there, okay? So you found a trial, or you're interested in looking at one. You want to first know that that trial, it has what we call reasonably good external validity. So what patient population did that trial test their hypothesis on? Did they use males that were young and depressed who had at least one other treatment? If they did, oh my God, that's awesome for the first PICO that I had. If they used elderly people who had never tried an antidepressant before, those results may or may not apply to my patient. So I'm less into it. But the fact that I thought about that ahead of time and I looked and I found something that related to a similar population or not, very helpful, right? So looking at the external validity, would these results of this trial apply to my patient or not? And then study design. So is it the right design? So did they use an RCT for a therapy question or a cohort design for a different type of question? Or are they a pharmacoeconomic design that helps inform whether pharmacare should cover it or not? There's a whole other analysis and types of trial designs that answer questions that base decisions around funding decisions for a societal perspective. And then once you've decided the design is good, you think, and the population is right, part of that design feature is, did it have reasonable things that meant I'm going to believe the results of the trial? So we think of that as internal validity. So are the pieces of that trial sound? So some of the pieces are, was it randomized? Was it blinded? Was there allocation concealment? Did they pick a good outcome? Those kinds of things. Were enough patients available at the end of the trial to make good decisions? So that's the internal validity of the trial. If the trial didn't have those designs, and it wasn't likely that you're going to believe the results, why even look at any of these things, right? So there's many trials that are out there that didn't use a good design, and I spend 0 time looking at them because I don't think that even if they told me the drug worked or didn't work, I would put a lot of faith or stock in that outcome. So assuming right population, good internal validity, good design, I then look at the results. Were the results meaningful clinically? Not necessarily statistically, but clinically. Were they useful? Was the outcome measure of interest? Was it that little change in the little gap in my knee, or was it pain reduction? So what did they actually look at? Will they be applied to my particular question? So these are like the things that I do when I'm looking at a study. Right patient population, right design, good outcomes, magnitude is big, okay, this is working for me, or not, okay? So just giving you a sense of what we look for. Because many people, and I think some of you who walked in this room and many people viewing this video, think that just because it's published in a really, really good place, that's all you need to know. And really, there's no real chance of you being misled. But thankfully, and James went above and beyond for this, we realized the reality here. I do appreciate him giving us this picture. When you look closer,
No hair.
when you look closer, the reality is that not all trials do have the right fundamentals, and you can be misled if you're not applying appropriate pieces of critical appraisal. So I mentioned this very briefly, that these are the things that I look for in a good trial design. They don't have to have all 5 of them. If they do, oh my God, I'm paying a lot of attention to what they're saying. If they don't, I'm probably not paying as much attention to the kind of results that come out of that trial.
And there's no magic to how many of those you have to make a good trial. It's almost like a gut feeling, and it depends on what you're studying and so on. And obviously, if it's not randomized, then it's not a randomized controlled trial. I mean, that's by definition. But the rest of that stuff is nice to have, but certainly not essential. And we're not going to do that right.
And sometimes it's impossible to have that.
Yeah.
You might have a therapy that it's very hard for the therapy's 10 years long. It's not likely you'll have more than 80% in that trial if you could. Or they couldn't measure the really valid, important clinical outcome because it happens so infrequently. But there's some other outcome that may be a good surrogate of that maybe is reasonable to measure if there's a good relationship, and that's been proven.
Go ahead. We will. We're going to go over
Yeah.
each one of these things
I'm
in
gonna
detail.
define
We're
them.
just framing this to
Yeah.
let you know we're going to talk about that.
I just wanted to tee us up just before the break and seeing that it's noon.
Yeah. So we're going to take a break here, and then we're going to spend. And you will get. We hope you will get why we're doing this once we start to get to the therapies and talking about it. I know you're probably going, well, just get on with it. Well, you need to understand this framework, and most of you will get it by the time we leave here after the 5-week course that you're now enrolled in.